with Emily Grundy from the Cambridge Centre for Population Studies, Department of Geography. We'll be talking on the demography of ageing.
Thank you very much for that, and thank you very much, Carol, for inviting me. I'm really pleased to be here, and I also feel a bit embarrassed because Carol and her colleagues do so much work on ageing that I think it's very sort of noble in a way to come and ask somebody else to be talking on an ageing-related topic without discussing her own work and that of her colleagues. But perhaps you all know what it is. Now, I should say there's a kind of interesting behavioural thing which has come to light already, which is that only the women followed the instructions to limit the number of slides to 8. So that explains why some of my slides are sort of clever combinations of putting things on them, because I found that quite a difficult challenge, but I did stick to it. So this first thing is just an overview of the demographic background, which I'm sure everybody's aware of, and which really affects all aspects of public health as well as many other areas, which is the ageing of the population, not just the UK population, not just the European population, but now really a global population ageing too. And this just shows the proportions in age groups over 75 for about the last 100 years or so and into the future, and quite a large change which is perceived to be causing all kinds of problems, but may also have some advantages that we could perhaps talk about. Now, the determinants of this from a demographic perspective are declines in fertility rates, and improvements in life expectancy, declines in mortality. And in most countries like the UK, which have got fairly old populations, mortality is now the predominant driver of further population ageing. So one of these slides shows, that panel shows long-term declines in fertility rates, a rough indicator of births per woman for several countries. And you can see this rapid fall, but then interspersed a bit with the post-war baby boom, then a birth dearth. Very recently there's been a slight upturn in fertility, but some countries like Italy still have very low birth rates. There's some interesting things behind this in terms of changes in distributions of family sizes, so that if we look at the earlier phase, there were far more people with very big families, but actually also higher proportions than more recently of people with no children or only one child, and I'll come on to that. And then this shows just an example. This is the increase in female life expectancy. This isn't actually for one particular population. Here they've taken the highest rate for any population, which some people might query possibly, but it shows this incredible rise, and it's fairly well established now that there's no sort of particular biological limit on life expectancy in the sense of any age at which people are sort of programmed to die off or whatever, but nearly all policymakers have consistently underestimated improvements in life expectancy. Now, as I said, the kind of things that I'm interested in are how these changes affect health and well-being, thinking both in terms of how they influence, say, support systems for older people, and also the life courses, changes in life courses which are a sort of part and parcel of that demographic change. What are those implications for health and well-being in later life? So some of the work we've been doing is, for example, modelling effects of changes in fertility and mortality on things like availability of children in the future, and then putting that together with what we know about influences in intergenerational support flows to try to make some projections perhaps of need for various services. Important to recognise, of course, that older people provide a lot of support to children and grandchildren. And in fact, one of the encouraging things about the improvements in mortality is now essentially all children have at least one grandparent available in a demographic sense until they reach adulthood. And we know that that has an effect on use of A&E and all kinds of other things, so some benefits. So this is just an example for various populations which together make up a large proportion of the EU population, showing projections of the proportion of people over 75 without a living child. And you might be interested to see that this has actually tended to fall during the early part of this century, because in the past there was this wider divergence in family sizes, but also because, of course, improvements in mortality have meant more survival of children to their parents' older age. But we are approaching a time when different demographic shifts which have happened since about the 1950s will cause this to increase again. So these shifts too affect the, if you like, the balance of generations within families, proportions of people who've got older or younger generation relatives alive at a particular phase. So this shows modelling the proportion of women at age 50 who would still have a mother alive, which is quite relevant perhaps in terms of responsibilities of people in midlife, and then the proportion of 80-year-old women who've still got at least one child, have got one child still alive. And so you can see the 80-year-old, the red line, this is women over 80 who've still got a child alive. This has actually been increasing because of these demographic shifts, but will start to plummet again quite rapidly. The proportion of 50-year-olds who've still got a mother alive, this has also been increasing rapidly, but will stabilise once we get to the period where we've had a couple of generations of people delaying childbearing. So the woman of 50's mother, instead of being sort of 75, might be 95. So those are some of the parameters, if you like, that affect the population level, and I think have large implications for public health and many other things. But I and collaborators are also now interested in how these life course dimensions of people's demographic histories affect their well-being in later life. So this is trying to really bring together literature which has looked at things like the influence of socioeconomic inequalities with the literature that's looked at effects of, say, marital disruption and various other things on health and well-being, and focusing particularly, what I will briefly talk about, on partnership and parenting histories, which have changed quite considerably among the generations now who will in the future be the older population. And that there are sort of potential benefits of people having had children expect might lead to improvements in health in later life. One is that throughout their life course they may have had an incentive to healthier behaviours, less risky behaviours, more social involvement, and of course in older ages we would expect they might be able to have more social support from children, and we know that those are also all positive things. But on the other hand, bringing up children is very expensive. It can also be highly stressful, expose you to more infections, so that there are various challenges, health potential challenges as well. And of course we would expect that this balance would vary by things like availability of social and economic resources, whether people are lone parents or married, rich or poor, and so forth, and possibly also as to whether the social public policy is, say, supportive of families bringing up children or not. So, for example, most previous studies suggest that the childless and the high parity, people with large families, have the worst health. Certainly in case of childless people, there are various things we have to take into account, that some people might have health problems early in life which reduce their chance of becoming a parent. But there's a quite interesting difference between, say, Nordic countries and England and Wales and USA and other places, in that in the Nordic countries, high parity seems to be possibly not have this sort of penalty. And it's been suggested, or in fact our collaborators we suggested, possibly this might be related to the much more family-friendly society in Nordic countries. But in terms of the trying to unpick the actual dynamics of how that works, we've been trying to look at things like differences in cause-specific mortality, but also decompose the pathways from particular experiences to particular outcomes. So this shows associations between number of children women have had and their risk of their odds of death at a particular time from various causes, and it takes into account obviously things like education, marital status and various other things. And here you can see that the parity 0 people, all these points are above 1. That means they have higher mortality from those causes than the reference category, which is women who've got 2 children. And there are particularly raised risks for things like alcohol-related mortality, which is more or less inversely associated with number of children. So this is consistent with this idea that the people who have children, they might have healthier lifestyles perhaps to begin with. We know that very high alcohol consumption might affect people's ability to have children, and that also that they kind of become responsible parents, reduce their etc., and they're kind of vaguely similar things for things we know are related to smoking. However, when we look at England, there's a slightly different picture. I should say in Norway, women with larger families, their overall mortality risk isn't particularly raised. And where it is raised, same for men, it's only for people in the less economically advantaged groups, which is consistent with this idea that having a big family will be more stressful if you've got to work very hard to look after them. Now in England, these results from analysis of the English longitudinal study of ageing, which Felicia is not here, but she was involved very much in setting this up. So here we're trying to find out what are the mechanisms which lead to the results that we find in this study, that women with 4 children have higher risks of various poor health outcomes than women with 2. And the outcomes we're looking at here are long-term illness, which limits their activities, and something called allostatic load, which is based on biomarker data and is a measure of, it's meant to be a measure of, if you like, accumulated stress throughout in terms of mechanisms, compensating mechanisms throughout the life course. I could explain a bit more about that if anyone was interested. And we're also trying to see, so what these diagrams show you essentially is we're trying to find out how much of this relationship between having more children and these outcomes, which we know exists in the other model, which if I'd been allowed more than 8 slides I might have shown you, how much of it is mediated, operates through these hypothesized important things like lifestyle behaviors, wealth and social support and strain. So we find, not surprisingly, that women who've got more children have less wealth. That's a negative sign up to wealth. We know that, and wealth impacts on these outcomes, these health outcomes. So part of the reason their health might be worse is they're poorer, they've got less wealth. But they also have more smoking, it's a positive sign, worse physical activity, and more social strain. There's also a measure of social support, but that wasn't significant. So these women with larger family sizes, perhaps rather differently from that Norwegian pattern, it appears that actually their health-related behaviours are worse, and that is part of the mediates these associations. And that in itself is actually, quite a bit of that is to do with a lot of these women with larger families are people who started childbearing early, and that is associated with quite a lot of later health challenges and poorer health-related behaviours. I should say this model, we do try and control for a measure of health in childhood, although it's not totally adequate. So I've only had time to illustrate one aspect of this kind of work, but we've also been looking at things like, does having more children increase your chance of social contact, increase your chance of getting help, reduce your risk of entering a nursing home and so forth, and at various other populations and health outcomes and men. So we do find if you've got more children, you do have higher social contacts overall than the childless, but there's not a huge benefit from having larger numbers. What there is a big benefit of having a daughter, you won't be surprised to learn. Again, in terms of your risk of going into a nursing home, if you've got a certain number of children, that risk is lower than if you have none, but they're not a huge benefit from having lots of extra children. And in general, parents of smallish families have lower mortality, better health, and better cognition. And there are complicated reasons behind that, some of which I've tried to highlight. But then also large family size, high parity, in some populations, including this one, is associated with higher mortality and some of these worse health, as we've seen. And there are also things that are part of the way towards having larger families, like starting childbearing early and having short birth intervals, which we've also found associated with poorer outcomes. So it's a complex, the things that we're trying to work on, myself and colleagues, is a complex mixture of trying to unpick sort of social, biological, but also contextual and policy influences on how these aspects of life courses, which are shaping the size and structure of the population, may also have implications for individuals and families in their own later life. So thank you.